Hello, and welcome to the lab. It's a new edition of Education is the Best Medicine, and we are starting our Zoom series. I will be bringing guests in. Uh, I'm learning the technology now, and this is our first show. So thank you. Thanks for tuning in. I'm going to send a text to my Facebook family and tell them thank them for tuning in. We of course got started a little bit late because I'm learning the technology, and I think I'm a lifelong learner. So behind me is my logo. Education is the best medicine. I want to thank a brother that's been on the show, Kaya Fortune, for helping evolve that image. And I think what it means is I have a love of people of color and accenting African features and all those kinds of things. um, I want to again thank you for tuning in, and kind of wanted to talk about some of the things that I've been seeing, and maybe you'll get a chance learning how to do uh, the ability to what I'm talking about for everyone to see it. It's this is data driven. This GPT chat. This is all open evidence. This is community input. It's all those kinds of things, and so that is the modus of this. And so, with that being said, again, I want to welcome you to the new platform. I want to thank Atomology, the leadership of this, and his hand in hand work with me to get this started. We've been talking about it for a while, and now I think I have the time and the ability to do that. It's a work in progress. All this stuff is a work in progress. So, welcome to the new edition of Education is the Best Medicine. And so, wanted to kind of talk a little bit about a few things that I've been seeing and kind of that's concerned me, and I wanted to make sure that we were on pace. We're in technology. Technology is driving a lot of the interactions that we have and we face, and I think that we have to be okay with that technology and learning new things. I think that if nothing else in this last year, I've learned to learn new things. And so I think that with that being said, it's always great to be a part of a social gathering, which I think as people that watch Education Best Medicine and all my contact in the village, and want to give a special shout out to Jeffrey Pete. Happy birthday to you, sir. May you have many more years of life and love, and thank you for being a part of my life and shaping the kind of person that I am. Jeffrey was very Jeffrey Pete of Jeffrey's Inner Circle was always ahead of his time in terms of as it related to Black folks and related to our condition and related to voicing that issue. And so he is kind of like a male friend, mentor, brother in arms. We talked about, he said we had raised a lot of hell together. I said, we did, and we still have to do more. You can't stop. You have to do more. I'm going to send a quick note out to the Facebook family. Watch on believe platforms. Education is the best medicine. And I want to thank um, uh, one of my mentors, Marvin X. We're going to have him on. Marvin, this is the iteration. So you tell folks that I want him to know that he's going to come on and have a discussion about, being a grandfather and a whole village of females, and so that's really kind of exciting. This is Education the Best Medicine. This is Believe Radio, radio gospel station. Check our other shows out, our other platforms. I feel so blessed to be able to do this. I feel so blessed to be working. I'm in a really exciting clinical practice, and it's just nice to have that kind of work environment and that work role. And so I'm really excited. I want to say hello to Dr. Green and Dr. Michael Lenore and his wife, who I think is retired, Mrs. Lenore. Have a good time. And so I want to talk about technology, and I'm so happy to be a part of this circle. And let's get started. I'm working like 40 hours a week now, and I believe to be one of the top-notch Bay Area community clinics, and a lot of internal medicine, a lot of family practice, a lot of social issue addictions, trauma issues, primary care. And I think that one of the things that Prime Medical Records has done has, allowed me to document in a more meaningful and intelligent manner. And I didn't wear a bow tie today because we're in the lab right now. So that is going to return along with, a whole bevy of things I'm excited about. This platform is going to really move forward. We're going to move this play on my son, Kenyatta, the new grandkid, his partner, and keep it moving. I want to say hello to my girls out there in Reno, Nevada, and all over. I'm looking for you. I'm going to try to contact you as your grandfather. So just put it out there. I'm going to start throwing their names out there and tell them that they need to get a hold of me. This is why I'm on this social media platform, because I want my girls to be in touch with me and they know who they are, and that kind of thing. So, and we're going to make some things change too. That's why we have to talk, my grandchildren, girls. Anyway, that being said, I've been seeing a lot of breast cancer. And so, and what I mean, I saw 3 cases in 1 week. And all of each different stages. And it got me to thinking about breast cancer as a particular etiology, a disease. And so, of course, I had to go and, I popped a question in the GPT chat. Yeah, GPT chat, open evidence, clinical experience. That's what motivates my talk. And I think that for a young woman that gets cancer, it really does change her invincibility. I'm thinking about a young woman named Gina Dawson who had a bloodborne leukemia and was just a master dancer. That's what the connection between her and Dr. Green, just a master dancers. And so I think we don't want to lose the dance in us. We don't want to lose the hope in us. It never is as dark as what we've seen. I've cried rivers, and I will continue to keep the faith, baby. Adam Clayton Powell. So I asked GPT chat, I said, breast cancer, in the breast cancer context, I'm a practicing PA in clinical practice, had 3 women between the ages of 26, 27, 50s. I don't talk about these women. These are women I've seen over my practice. And so just today I'm kind of focusing on the first time I saw breast cancer. I did a show with a group of Black women, one of who studied mammographer. She's a mammogram master, and 2 survivors. And so that's why I got into the discussion around survival, because you don't ever end these things. You continue to survive. You continue to thrive. So there were 2 Black women and 1 young white woman, and and so and most of the doctors range from the initial diagnosis of getting a mammogram to the stage of biopsy to see the breast surgeon. So let me say this to the ladies right now, is that you have to advocate for yourself, because if you don't advocate for yourself, no one's going to advocate for you. And I realized as I was trying to do referrals for all these women, how convoluted the system was. And if you weren't dealing in evidence-based medicine to discuss why they need these particular tests, you would get nowhere. So I'm a believer in this literature. I'm a believer as it relates to this as in the Western as to breast cancer, because far too many women don't know they have breast cancer. These cancers usually are discovered by women from a historical standpoint. You know, self breast exam isn't as reliable as we think it should be, and I have to agree with them, because it should be standard. You can feel something, you can have history, but you need a picture. You need to see inside a picture, because the hands and the tips of the fingers of a clinician are only so sensitive. And usually, if a woman can feel a mass that size on her breast or in her axillary area, that means that our area is in the armpit, then we've got a problem. So, that being said, I asked the question in regards to these three cases, and so the reply was that he says the three cases that in these women are in the mid-20s to 50s is reflects trends that clinicians across the U.S. are seeing. So this is not an anomaly. This is what's going on. This is the clinical concern that we see as clinicians as we order that mammogram or tell women to do a self-breast exam, or again, with the changing of the dates and the times that women can get mammograms, I'm having to advocate more so. I had a young, having women that say, my mom's had breast cancer, but the age is definitely out of the 30-year range. So if a young woman is in her 25 to 30, I think, to 40, they can't get a mammogram. You can get it, but the clinician has to advocate for it and justify why, out of this age range, because it's a money thing, always a money thing, out of this age range, why are you requesting a mammogram in a woman that's young? And we'll talk about that. And so I asked the question, the who, what, when, where, and why question. And it says breast cancer in the United States 2026, a clinical perspective. Again, talk to your doctor, talk to your family members. I'll take my word for it, read about it. Again, I will always advocate, is this point of my career in the next 10, 12 years I have to practice, is that we have to educate for self-education. You have to be a lifelong learner. You can't trust the evidence. You have to find the evidence. You have to be sure what you're asking for is happening. Says the who gets breast cancer? Did you know men get breast cancer too? But the who, it says all women are at risk, with a lifetime risk in the U.S. of 1 in 8. So 1 in 8 women, you kind of did a roll, 1 in 8 of those women are at risk for breast cancer. It's over 316,000 new invasive cases annually in the U.S. and tens of thousands resulting in deaths. As special as my queens is, black women similarly or slightly lower incidence than white women, but 36 to 42%, I'm going to say this again, 36 to 42% have a higher mortality. What does that mean? It means that they're less likely to get it, but if they get it, it's more likely to kill them. At over 40%, that's a lot. Clinical demographic patterns. Again, this is GBT-TAT. This is open evidence. This is up to date. is calling from these sources, my own clinical experience, um, says that clinical demographic patterns group white women highest incidence. So now you see why there's such a real move about breast cancer society, about the breast cancer runs, about advocating for mammograms, about women's care, about advocacy in that care. Because in this country, white women have the highest incidence. But again, black women have the highest mortality. Now, we're just talking white and black. I didn't even put in, Pacific Asian, Hispanic, African, European. This is just the U.S. Younger women, less than 40, less common, but often more aggressive. So when young women, those young women that we say don't get breast cancer, that can't get a mammogram, have a breast mass, and you have to fight with the insurance company about getting a mammogram, a basic mammogram, because the mammogram will tell a story. Because the radiology world is very good. I love their reports, even to the assistant saying this person needs a biopsy and needs a women 50 to 70 have the highest overall risk. So medicine is like this. They play the risk game. But I've been practicing almost 44 years. And so the risk game now moves to a dynamic I didn't know and didn't have to think about with this young women of color. And as I speak to you and talk about this, I have a couple of women now I have to advocate for them getting a mammogram because they have a high risk. Their first line, their mother or their grandmother had breast cancer. Direct line. Genetic direct line. This is Believe Radio. And this is a 24-hour gospel channel. I'm George Prison. We're doing our first uh, tele show. Thank you for walking on the moon with me and taking this first step. Hey, it's gonna be better. We're gonna get better. I got some thoughts about how to provide data. We have a whole circle of shows from Education Best Message. I'll be playing. Record the show and talking to some very powerful folk, and I mean powerful in the fact that they are impactful. The past president of Lake College, and she's doing a lot of business ventures. I forget the doctor's name, but we're gonna have her on. We got a whole slew of folks. We're gonna take this. Number two, disease pattern. How does things happen in a person's body? What goes on, particularly in breast cancer, is multifactorial diet. It's just not one. It's multifactorial. Breast cancer or TNBC. The important disparity, because I also asked what was the discussion around racism, structural racism, and institutional racism in the care of women with breast cancer in 2026. They answered the question or posed some points that I think are very important. Black women are significantly more likely to develop TNBC. That's the triple negative breast cancer, which is lethal. A biologically aggressive tumor with few targeted therapies. So in 2026, we have a younger group of women getting a smaller group of women, particularly African American, getting breast cancer, but it is coarse triple negative breast cancer, or TNBC, and Black women are more likely to develop TNBC, a biologically aggressive tumor with few targeted therapy. So, if you have ER-PR positive or HERS2 positive, you've got targeted therapies for you. But if you're a Black woman with triple negative breast cancer, then no mas. We don't have anything for you. Now, how does that make you feel? That we don't have therapy for those that are affected more severely, and it could be younger, but we have therapies for those that have the highest incidence. And what I'm saying, white women have the highest incidence, so they have the best therapies. Black women have the worst prognosis. In 2026, although they're developing some therapies now, I see things in this CRISP issue. I see things in, really targeted therapies are probably going to turn that tumor against it, just like HIV, but it has to be scripted for people of color so that they don't get sick from it, or the side effects are minimal. So therefore, you have to study those women. And a lot of those women won't be studied because they're afraid. Simple as that. And then, look, Tuskegee studies, Henrietta Lacks, syphilis studies. Oh, you got a track record here that tells you not to mess around. That being said, 3, age trends. It's around, it's 2:30, and man, on a real different kind of health note, I had to break the monotony, and I had originally done the show a couple months ago. It's in the can, and about health issues. So first of all, I think a lot of people of color are lactose intolerant and don't consume milk and pass breast milk. Most people of color don't consume. A lot of us don't consume lactose or milk products because it gives us gas. So the Trump administration wants you to drink whole milk. Here's what the actual health experts want you to know. The current commander and the secretary, Trump and Kennedy, have donned milk mustaches on social media recently, declaring that whole milk is back, encouraging Americans to drink up. It said it follows the release of a 2025-30 dietary guidelines, which recommends consuming 3 servings a day of full-fat dairy, including milk, as a part of a 2,000-calorie day diet, noting dairy is an excellent source of protein, healthy fats, vitamins, and minerals. But aren't Americans too fat? Aren't we having an epidemic of obesity? This is when a recommendation has not only a political tilt to it, but an economic tilt to it. Because it comes from the health secretary and the person occupying the White House. That's when it's a concern. That's when politics enters our food chain. Do I drink milk? Occasionally. But it's not something I can do because I get diarrhea from it. But everything in moderation. Let's see what else it says here. It says that the DGA lists full fat dairy as a healthy fat. Think about that. One size fits all. We could all sing it together. You think so? The discussion we have to have is awesome about that. What do you think about government encroachment into everybody drinking milk? And does everybody want to drink milk? Some of my, I think some of my Indian patients who think the cow is sacred, I don't know if they would do that, nor eat it. I have a large population that's vegan. They don't eat any meat. I know that's supposed to be part, and not small government, right? What are we talking about small government when you're telling people to drink milk as a governmental piece? So this is when you have to question the data that's coming out, because the data that's coming out is laden with bias, and when it's laden with bias, it has two things about confusing people and probably having people that shouldn't be doing something doing it. And again, get back to the don't tread on me, and it's become inclusion and as opposed to exclusion, and my myopic thinking says that the real introduction of the Republic as we know it sounds like something that come out of Star Wars, right? The Republic. Didn't the Republic just tear things up in Star Wars? They had one leader. And a military second to none. I think about Star Wars, right? So, okay. My brain thinks that way. But, on the side, what happened to the Republic, right? And a woman would lead them. But I say make lemons out of lemonade. We have to always be kind of now observant of the things we're reading and listening to, and kind of observe them as evidence-based sometimes, and things that are taken with a grain of salt, and understand that should be the driver of this, the health of the nation, not whether you drink milk. The recommendation also chose the skim on low-fat milk was intended to lower overall fat and saturated fat in the American diet with the goal of improving heart health. She said, however, obesity and heart disease continue to increase. I said before, I didn't even think about that. Research has been evaluating whether low dairy choices have had a heart impact. So we're not even clear about that. So that's just conversation. And this article was from the Huffington Post. And it said that I'm concerned about the possible impact of people recognize whole milk as high-fat animal products are a reference on the new food pyramid. Misrepresenting is a recommendation to simply increase the intake of both. And are you drinking milk even though you're lactose intolerant? Come on. In a 2025 study published in the American Journal of Clinical Nutrition found that consuming milk yogurt, in regards to the fat content, is neutrally associated with cardiovascular disease. However, a research review suggests that the higher intake of fat milk will link to increased risk of coronary heart disease. So you can't have your cake and eat it too. So for those of us that drink milk for our bones, is one type of milk better than for bone health? All cow milk contains vitamin D and calcium, which are the vital for the bone health, Wolfen said, and the quantities are similar across milk varieties across the USDA. Calcium, about 325 milligrams in non-fat milk, 306 milligrams in whole milk, and 300 and some milligrams in 2%. Vitamin D content was 1.8. Kind of standard. The fat content didn't impact bone health, though. Almost all skim milk and low-fat milks are vitamin fortified in the modern era of the U.S. So from a bone health perspective, there's probably not much to be gained from whole milk. Incorporating dairy into your diet is a good thing, as it adds calcium, vitamin D, and other key nutrients that are critical to good health, said Richard Terry, a family practice physician and vice president of health sciences in the Lake Erie College of Osteopathic Medicine. Say that's a bunch of mouthful. How about that? But you choose. But the type you choose is an individual's decision based on your health and overall diet. Not everyone needs to drink milk or skim milk or low milk. Whole milk may be beneficial for many people. Whole milk is already recommended for ages 12 to 24, and kids and adults who need extra calories from fat or can maintain weight. I can live with that as a note, but one size doesn't fit all. And to another thing to know is most people don't get enough calcium or vitamin D in their diets, and milk and other dairy are good sources of nutrients if it doesn't cause lactose intolerance. And so dairy is a critical component of the food pyramid. It's an excellent source of protein, calories. I was seeing a brother who was talking about uh, the concern around how this food pyramid and how it impact people of color. Again, I got to go left one more time before we go back to breast cancer, because breast cancer is interesting and I want to spend the rest of the time on it. Says what the Supreme Court, remember I did this in February 26th, what the Supreme Court decided, Learning Resources Inc. versus Trump asked one core question: can a president impose broad tariffs using emergency powers without Congress? Well, we know the answer, 6-3. It says holding the International Emergency Economic Powers Act, HEPA, HEPA, not HEPA, HEPA, does not authorize a president to impose tariffs. Tariffs are a form of taxation. The Constitution assigns taxing power to Congress, not the executive branch. Congress was clearly dedicated to such authority, and it did not do it here. So it wasn't that Trump was right. He wasn't put in check by a Congress that seems to be doing less than more. So I was I stopped at the disease pattern. Again, I want people to remember that Black women are significantly more likely to develop triple negative breast cancer, which is in a very aggressive form and with few therapies. I want that to stick to people's brains. Age trends. Here's something interesting. Median diagnosis age is 60-20 to 62. Again, mammogram age screening is, I think, around 40. You can advocate for 35. The EHRs kind of trigger us to do mammogram screening unless it's outside the purview and women ask for it. I've got a young lady I've got to advocate for as I do this talk. Thank you, everyone, for your support. Been a very interesting time. And one has to never forget that we are blessed, and that the ability to do all the things that you're doing are God-given, are Allah-given, our ancestors given, our parents given. So although the median diagnosis age is 60 to 22 approximation, the emerging trend, what's happening, what's going to go down now, not yesterday, not in the middle of the week, but now, increasing incidence of women under age 50, PDAO. That's my justification for getting this young lady a mammogram. Increasing incidence among young women under 40, especially Black women, women with dense breasts, women with genetic predispositions. That is 75% of the women I take care of. Excuse me, 95% of the women I take care of. Being facetious. It's the women with small breasts that think they've got really large breasts. So we have to. That's why I don't do women's exams. I don't do breast exams. Yeah, I leave that to my colleagues and those in women's health. Among women under 40, breast cancer incidence is higher in Black women than white women. Remember, white women have a larger incidence, but age, this becomes higher under age 40. So among women under 40, breast cancer incidence is higher in Black women than in white women. And that's deep. Look, I want to thank, again, I'm just thankful. I'm thankful for my ability to do what I do. I'm thankful for, waking up in the morning and having a right mind. I'm thankful being able to give people that have less than me something to do my due diligence, to be peaceful. So, in young onset, I often show we got about 15 minutes. We're gonna get through this stuff. It's good stuff. And so with younger women, younger onset, higher grade of those tumors. So they're more likely to have a really aggressive tumor, TBNC. So imagine your late 30s or 25 having an aggressive breast cancer tumor that has to be treated or it'll kill you. And there's no treatments for that particular breast cancer. Where geographic health system context, urban underserved communities, southern U.S. states, areas with limited screening access. So it's all about access. Urban, underserved. So in the Bay Area, if you don't have access, they used to be able to get free mammograms. Women could go for those. Now they're not paying for them anymore. These are cutbacks. These are probably these cutbacks where screening for would lead a woman sometimes to get to. And my good friends that did the first show with me about breast cancer mammograms, she did a field. She had a van and did mammograms across the Bay Area. Picked up women breast cancer wouldn't have known it. They had to fight for doing younger women because of those costs. Mortality gaps are particularly large in the major metropolitan regions such as Atlanta, Chicago, Los Angeles, Memphis, and where disparities in late-stage diagnosis remain high. And why is that? Well, racist, structural, institutional issues are an issue. And why? Clinical and social causes. Breast cancer outcomes reflect three intersecting layers: biological factors, genetic mutations that BRCA 1 and 2, the triple negative cancer prevalence, the tumor aggressiveness, and the breast density. And what it means by breast density, not what it means by breast density, not just large breasts, but those breasts have more compact tissue. Thereby, it's harder to do mammograms, or a tumor of sorts could live really good in that disc pack. That's why it's concerning me. Women are doing the young women are doing these breast enlargement enhancements, because it really puts you at more risk for breast cancer, because that you sit on the wall of your chest, which is a great area where blood flow transfers back and forth. This is Education's Best Medicine. We are a social activist organization. I want to thank all the people that acknowledge and watch the show, and I appreciate your support. The likes are great. Share with friends. We're going to have more guests on, but I believe in the hard data, the hard information that is not being talked about in my community. And when they start talking about those things in my community and stop minimizing them and not saying they're not important, then this one, I'll stop this. But this issue with women, in particular African American women, and breast cancer is a scary, scary, scary scenario. With young women, a scary, scary, scary scenario. With women with disc breast and genetic predisposition, a scary scenario. Clinical system factors: screening access, delayed biopsy, delayed treatment initiation, differences in oncological care. One thing about me and this particular issue, I really have to advocate and move the specialty appointments forward as quickly. So I'm talking about a week to 2 weeks, no longer. I'll come all urgent. I document using the data. I want the clinician to see that it's there and it needs to be dealt with. Radiology is real good about providing supportive information for moving the case forward. I want to thank all of my radiology colleagues for what they do, particularly those that focus on breast cancer screening and breast mass screening and breast screening, because that's what it is. Social determinants: income, transportation, of literacy, insurance access. That's why we're talking about this. I said, when's the last time I heard a show on breast cancer related to women of color and discussing the statistics and what we need to do and what is the treatment modality? Hadn't heard one. So share the show. Share it to your sisters and all the women of color that need to understand that this could happen to you. Although a blunt tool, the self-breast exam, still key. Anyway. Another place is the health professional, women's health professional, where you can get breast exams, and that changes everything. Your PCP picking up that mass is everything. But you have to tell them and be okay with the breast exam. Politics, chaperones, all those things limit access because it slows down the visit. But I believe the chaperones. I believe in all that. I think it's fair. People have abused too much power. Anyway, structural institutional racism and breast cancer outcomes. In my healthcare equity literature, disparities are increasingly attributed to structural racism rather than race itself. Structural racism refers to policies and systems that produce unequal access to health resources. Let me read that again. In modern health equity literature, disparities are increasingly attributed to structural racism rather than race itself. Structural racism refers to policies and systems that produce unequal access to health resources. Research shows that these forces influence breast cancer outcomes in multiple points in the care way, to where people get discouraged, they get pissed, and I'm thinking about a movie where the mother's daughter is sick, and she sees this really nice person, and then she just flips, and just starts telling them, "You better take care of my daughter." It was, kind of like a aha moment, because that's how that person's feeling. Not only the person that's having the care, but their family members. Increasingly, my caring tells the family. Increasingly, I have to, and I request that the family be with their partner, loved one, child, so we can have a full discussion. That's why I use Doximity, so we can record a discussion and have a real discussion. Not just one that's superficial. I get 20 minutes per patient. But interestingly enough, my conversations, when I look in the recordings, 5-10 minutes maybe, for what they want to say in totality. And I said, "Oh, yeah, is there anything else? Anything else?" They said no. So people need their place at the table, need to be able to have that conversation. Screening access. Historically, mammogram programs were less successful in minority neighborhoods. Lower rates of regular screening, consequences, late stage diagnosis, worse prognosis. Oh, that rhymes. Late stage at diagnosis, worse prognosis. That's something to remember. Late stage at diagnosis. So if you don't do the screenings, if you're not seen, if you're not evaluated, usually when it's caught, it's called late in the game. And I really put this out to my LGBT community, transgender, and all the undecided folks. You still need the screenings in your gender, in the gender you were born, so that things aren't missed. I know it's uncomfortable. You do it. You don't feel what's the point. It's survival and living a quality life with your partner. Low income patients lack primary care and therefore receive few screening mammograms. And why is that? Well, COVID had us lose maybe, I'd say, 60% of the providers dropped out. because they thought the epidemic was going to be longer than what it was, but with the advent of the medicines, it knocked it down. We're seeing a revisiting of viral illness now. And what I mean by that is that chronic cough, runny nose, congestion, all the hallmarks of viral or in some cases bacterial. You do the screenings. I do RSV. I do strep. I do COVID. I do influenza. All negative. I believe there's a variant from all these viral things now, and folks that aren't getting vaccinated, we've lost that pool of folks that created that safety buffer. The kids aren't getting vaccinated as much, nor their parents. Something to think about. Something that can be prevented. Diagnostic delay. Black women experience longer time to biopsy, longer time to oncology referral, longer time to treatment initiation. And something was driving my brain when I saw this, that I need to get them into care, get them seen by the surgeon as quickly as I can. Once given the referral, I give you a week, and then it's like, what's going on here? I haven't heard from you, nor have you made your appointment. That's what we have to do now. It's not just a medical legal issue. It is what you have to do. Because people have busy lives. My women of color are so busy with family and children and stuff and school and work and trying to be human. Small delays, 30 to 60 days, can worsen survival for aggressive cancers. I knew that. I knew that from being a clinician, that the longer the delay from the time that you see the biopsy, you see the mass, the longer that takes, the less likely they are on treatment. Because it's going to take 40 days because you got to get onto the surgeon's schedule. So it has to be lightning quick in order to be effective. And if something throws it off, family illness, have to travel, then usually care is delayed and more risk of not the outcome that we want. Treatment differences. Studies show disparities in access to high volume cancer centers, breast reconstruction, radiation therapy, novel treatment therapies. And one big thing about this radiation is for women of color is their hair. They don't want to lose their hair. It's like I tell men about prostate cancer. It may mess with your erection, but you'll be around to see your grandkids and take the girl wife on that next cruise and see your son play more ball and graduate, or your granddaughter. That's what it's about. It's not about you anymore. It's about the people that want you, care you, and love you, that have made you who you are. Neighborhood and environmental effects. Now, this is a new one. Structural factors includes residential segregation, food deserts, environmental toxin exposures, chronic stress. Chronic stress. I can relate to that. Folks, we've got 2 more minutes. I want to thank you guys for tuning in and appreciate you and all the good things that have happened. And we're going to keep this moving. These factors influence immune function, obesity rates, and comorbid disease. Clinical rate, why your case makes sense. Seeing 26-year-old 2 women in their 50s reflects real epidemiology. Younger patient population, possible contributors. Genetic predisposition, just breast tissue, delayed detection, aggressive subtype. Women in the 50s, this is the peak screening age where many cancers are detected through mammogram. Hey, take home message, ladies, get your mammogram. I know it hurts. The breasts are tender. Yeah, get your mammogram. I saw the presence of a mass on the mammogram, which initiate the whole process. But you don't get it. I ain't got no picture. We just talking. Mortality versus incident. Key takeaway. One of the most striking facts in U.S. oncology. Black women have slightly lower incident, but 40% higher mortality. This is one of the clearest examples of health inequity in American medicine. Practical implications for primary care. Frontline clinicians, PAs, MPs, MD, risk awareness. Consider early imaging and family history, high risk ethnicity, and suspicious symptoms under the age 40. Got to do it. Got to advocate for it. This young sister who I just met, she's absolutely right. And kind of like, you don't get it? It's a war. You don't get it? Increasing recommended start risk assessment at 25, screening by 40 at average risk, earlier for higher risk groups. Equity focused practice, aggressive follow-up of abnormal imaging, ensure biopsy completion, navigate services for oncology referrals, patient education on symptoms. The bottom line, breast disparities in use are not primarily biological, they are structural. Breast cancer disparities in the U.S. are not primarily biological, they are structural. The difference between who gets cancer and who dies from cancer is heavily influenced by access to early detection, equality treatment, social determinants of health. We talk about all the time. Clinical takeaway. Younger Black women with breast cancer is not rare anymore, and clinicians should maintain high suspicion when symptoms appear, even when screening at a young age. My granddaughters, Nisha Bisha. We all have to be mindful of those young girls in our lives that need to understand that you may need to get screened. I want to thank you guys for watching. It's been a great show. We'll see you next week. Appreciate it. Love, peace out.